Today our topic is idiopathic interstitial pneumonias, something new, something not so new. The other day we were discussing the evolution of diagnostic techniques in diffuse parenchymal lung disease, especially the situation before the advent of HRCT and subsequently. It was in 2002 that a consensus classification came and the world had a comprehensive idea of how to look at diffuse parenchymal lung disease. But after 10 years in 2011 and between 2011 and 2013 further things crystallized because of a second meeting. So, that is what we are discussing today. So, the learning points of today's discussion are the revised classification with inclusion of a new entity, more clarity on the idiopathic NSIP, that is non-specific interstitial pneumonia, something new on idiopathic pulmonary fibrosis, unclassifiable disease, and also a step towards pragmatic classification. So, is it time for revision? Yes. As I said earlier, it was in 2002 the ATS ERS classification came. So, when it became 10 years, the world felt that it is time to look at it again. It had its own impacts, the previous classification I mean. It provided more secure diagnostic subsets, better appreciation of non-IPF usual interstitial pneumonias, and better diagnosis of NSIP and RBILD, and better prognostication. But it had its own limitations too. For example, very few actually underwent lung biopsy, and there was coexistence and overlap of some entities. Some entities still remained unclassifiable, and finally an important minority had no final diagnosis. So, the new effort started. 24 pulmonologists, 4 radiologists, 4 pathologists, 4 methodologists and 1 librarian came together, and 3,879 articles were retrieved from literature, which were finally reduced to 58 articles. And the new classification has been subjected to further discussion and clarification at various venues, an important one being the TRIST symposium, which was conducted in April 2013, Athol Wells, the well renowned pulmonologist of Royal Brompton Hospital, delivering that. So, the histologic and clinical classification of idiopathic interstitial pneumonias as we did it in 2002 were as follows. For example, the histological pattern of UIP was the clinical diagnosis, was the basis of the clinical diagnosis of idiopathic pulmonary fibrosis. Then respiratory bronchiolitis and disquamative interstitial pneumonia, both of them were smoking induced lung diseases, and it had its own corresponding patterns. OP or organizing pneumonia was the pathological basis of the entity called cryptogenic organizing pneumonia. DAD or diffuse alveolar damage was the pathological pattern for the clinical diagnosis of acute interstitial pneumonia, and non-specific interstitial pneumonia was called as such. Lymphoid interstitial pneumonia was the basis of that particular entity. So, the new suggested classification is they divided them into major idiopathic interstitial pneumonias and rarer ones. The major idiopathic interstitial pneumonias as in the new classification are idiopathic pulmonary fibrosis, idiopathic non-specific interstitial pneumonia, RBILD, that is respiratory bronchiolitis interstitial lung disease, disquamative interstitial pneumonia, cryptogenic organizing pneumonia, and acute interstitial pneumonia. The two entities which were marked as rare entities are idiopathic lymphoid interstitial pneumonia and a totally new entity called idiopathic pleuropulmonary fibroelastosis. Finally, there remained a small group called unclassifiable idiopathic interstitial pneumonias. And also a clinical categorization was attempted. For example, the IPF and NSIP belong to idiopathic NSIP belong to chronic fibrosing idiopathic interstitial pneumonias. 2 are smoking related ones as before, that is RBILD and DIP, and 2 entities are coming under acute or subacute diseases. They are cryptogenic organizing pneumonia and acute interstitial pneumonia. So, categorization of major idiopathic interstitial pneumonia, I am just repeating these 3 groups, that is the rare group, chronic group, subacute group and smoking related group. But there are a few entities still in waiting, but we can forget them for the time being. Just to note what they are entities which might get clarified as and when we get more information in subsequent classifications. They are acute fibrinous and organizing pneumonia, bronchiolocentric pattern of IIP, familial interstitial pneumonia, about which we already know something, and a specific drug induced variety, especially following bleomycin. And one entity is been now recently incorporated, which as I said earlier is idiopathic pleuroparenchymal fibroelastosis. We will talk about that first, that being a new entity. This shows a fairly typical dense fibrosis and pleural thickening, mainly confined to upper zones, and the pathologists report an elastin framework and increasing fibrosis there. There were 7 cases from the west, but the fact is that from Japan already 37 cases were reported, when they used to call it by a specific name called Amitani disease. A case of suspected idiopathic pulmonary upper lobe fibrosis with acute exacerbation in Japan, when they used to call it Amitani disease. The original article is in Japanese, that has been reproduced here. You can identify that 82-year-old man on admission had röntgenologic images showing deterioration, and acute lung injury was diagnosed by transbronchial lung biopsy with steroid administration. Even though he initially responded to treatment, bilateral spontaneous pneumothorax resulted, and despite treatment he died of respiratory failure. That was which they considered as a separate entity. So, the key features are, most often they are middle-aged females, non-smokers or ex-smokers presenting with cough and progressive dyspnea. The HRCT showed upper lobe pleural irregularity and thickening with subjacent reticular pattern. It has got a very dense appearance in X-ray as well as CT. Associations are familial, repeated infections, aspergillosis, cystic fibrosis, etc. Potential biomarkers, gene expression, etc. were being explored, but none were recommended for clinical practice yet. This is another publication regarding this particular entity. And looking at the pictures, what you find is the pattern of fibrosis is predominantly apical or periapical, and they have a sharp contrast to the subjacent lung parenchyma. If you look at the histological pictures also, the elastin framework and the fibrotic lesions are sharply contrasting with subjacent lung parenchyma. This is another case where again you can see posteriorly located peri-upper zone plaque-like thick fibrotic pleural lesions. Another one. These are 5 different cases. All these show plaque-like thickened pleura which has got a sharp border with the corresponding or underlying lung parenchyma. It has its own differential diagnosis, of course. For example, asbestosis, connective tissue diseases, advanced fibrosing sarcoidosis, even chronic hypersensitivity pneumonia, simply apical caps as you usually find in tropical countries, especially with the history of probable tuberculosis in the past, radiation or drug induced interstitial lung disease, even scars related to emphysema can cause difficulty in differential diagnosis. The next is the new classification gave more clarity to idiopathic NSIP. That is, in 2002 we used to call it a provisional entity. It is no more a provisional entity. It has got very specific difference in clinical as well as histological and radiological features from the other non-specific interstitial pneumonias associated with collagen diseases, etc. That is, it has got important divergences between the series in HRCT finds, BAL findings and outcome data. The American Thoracic Society had a separate project also to study it further. The conclusions were idiopathic NSIP exists and has got typical clinical and HRCT features. Essentially, this diagnosis requires a dynamic, integrated, multidisciplinary approach because of overlap with other disorders. See the classical appearance of bilateral temporal homogeneity with the ground glass opacities. It occurs most often in middle-aged women who are never smokers, and it is characterized by relatively homogeneous expansion of the alveolar walls by inflammation and or fibrosis. NSIP may be idiopathic, but actually the more common entities are manifestations of collagen vascular diseases, hypersensitivity pneumonitis, drug induced lung disease and chronic interstitial lung disease complicating diffuse alveolar damage. Let us see which are the histologic, clinical and HRCT hallmarks of this entity. The histologic hallmark of NSIP is relative temporal and geographic homogeneity, the findings appearing to represent the same stage in evolution of the disease as distinct from the heterogeneity seen in usual interstitial pneumonia. The histologic findings may range from a predominantly inflammatory process which we call cellular NSIP to the other extreme, at the other extreme a predominant fibrosis which we term fibrotic NSIP. In cellular NSIP, the alveolar septa are thickened by infiltrates of lymphocytes and plasma cells, while in fibrotic NSIP the thickening is due to collagen accumulation. So, the presence of fibrosis in NSIP is obviously associated with a worse prognosis. What are the clinical hallmarks? Though NSIP has been described in patients ranging from as early as 9 years to old age as late as 78, the median age of onset of symptom is between 40 to 50, even when it is at least 10 years younger than the patients with IPF. Clinically, patients might present with symptoms similar to IPF, dyspnea and cough with a duration ranging from 6 months to 3 years. Patients with an exclusively inflammatory component, that is what we call as cellular NSIP, have an excellent prognosis with few reported deaths, while the reported median survival of patients with fibrotic NSIP ranges from 6 to 14 years. The prognosis of NSIP, whether cellular or fibrotic, however, is considerably better than usual interstitial pneumonia. What are the HRCT hallmarks? Once again, ground glass opacity, findings of fibrosis quite mild even when it occurs, and when it occurs you can see almost all the findings like traction bronchiectasis and bronchiolectasis, interlobular interstitial thickening, septal thickening and irregular interfaces, but all these findings will be much less than what you find in UIP. Honeycombing is typically uncommon and mild even when it occurs. There also will be a lower zone predominance of homogeneous ground glass opacities. Another finding which has been observed in NSIP is relative subpleural sparing, especially in the dorsal region of the lower lobes. Please remember that in usual interstitial pneumonia, whether it is part of IPF or not, what you find is a lower lobe predominance. This is another case of non-specific interstitial pneumonia in a 48-year-old woman. You find extensive bilateral ground glass opacities with a temporal homogeneity. The lesions appear to be of same duration, and it is obviously it is consistent with cellular NSIP. This is lesion in another case, a 74-year-old man, where you find the relative sparing in the subpleural region, diffuse bilateral ground glass opacities, but also evidence of mild reticulation and traction bronchiectasis. This is probably consistent with a mixed variety, that is mixed cellular and fibrotic NSIP. Now, let us go back to idiopathic pulmonary fibrosis. What are the areas of uncertainty in idiopathic pulmonary fibrosis? The world is continuing to concentrate on it. We are very much concerned whether, just like smoking, is it another predisposing factor for lung carcinoma. We still do not know the exact pathogenesis of UIP, and histologic predictors of prognosis are need to be sought again. The characteristics and causes of the entity called acute exacerbation or accelerated IPF requires further study. The pathogenesis of IPF has been looked at in detail by many workers. Just to concentrate on the middle paragraph, the current hypothesis is that the pathogenesis likely involves several components, including repetitive lung injury, inflammation, exaggerated deposition of collagen and extracellular matrix, recruitment and proliferation of fibroblasts, and typically an inappropriate wound healing response, which is responsible for the progressive fibrosis. It is important to remember that the temporal heterogeneity of the lesions, that is, the lesions reflecting different stages in the evolution of fibrosis, which leads to presence of old and active lesions at the same time. That is the hallmark of IPF. We were talking about possibility of cancer. This is a lung mass, obviously a lung cancer, in the background of a rather subtle or early case of idiopathic pulmonary fibrosis in the proper clinical setting. At least it is a case of a lung mass in the background of usual interstitial pneumonia. And remember that if you look at chest X-ray alone, it is very difficult to detect the possibility of such lesions. For example, this is a known case of IPF under follow-up. If you are taking only chest X-rays, you will stop with commenting there is evidence of reticulonodular shadowing and some fibrotic lesions in the lower zones. But if you look at the CT, these are CT documents which are 3 months apart. Something looked very sinister in the first picture itself, which was ignored and kept for follow-up. You can see that within another 3 months it has now assumed appearance of a more typical coexisting lung cancer. What is accelerated UIP? A retrospective chart review of several patients have been done in the past, and taking examples from a single study in which they were looking at the follow-up of 5 cases which were supposed to have accelerated UIP. All of them showed hypoxia and dyspnea on admission, and diffuse ground glass opacification was superimposed on reticular markings, and BAL showed marked neutrophilia. Histological findings from open lung biopsy or autopsy showed all features of UIP with superimposed features of acute lung injury, that is, the histologic manifestation being diffuse alveolar damage. I have borrowed this slide, rather snapped this slide from another presentation. Can you imagine that within 2 months this appearance can become so much worse in spite of continuing maintenance treatment? Yes, that can occur only with accelerated UIP. A subgroup of IPF patients, this is a study from the Public Library of Science journal, PLOS journal. They have shown an accelerated clinical course and a different gene expression pattern, where lungs of rapid progressors overexpressed genes involving morphogenesis, oxidative stress, migration bar proliferation, and genes from fibroblast and smooth muscle cells. So these highlight the variability in the prognosis and explain the difficulty in getting reproducible results in patients with IPF. Now, some of the practical implications of the diagnosis of IPF as from the new revised ATS, ERS, JRS, ALAT conference. You might note that unlike in 2002 where only the American Thoracic Society and European Respiratory Societies were involved, in the current one, that is the one which happened in 2011, also incorporated Japanese Respiratory Society and Association of Latin American Thoracic Societies. So, the updated evidence based guidelines for diagnosis and management of IPF were thus revised, where the main objective was to provide recommendations on the diagnosis and management of IPF based on a thorough review of evidence published till date. So, now there are at least two different entities. One is definite IP, second is possible UIP, and the third is inconsistent with the UIP. So, in patients demonstrating features that meet the criteria for possible UIP and or inconsistent with the UIP patterns, a surgical lung biopsy is indicated, not for classical clinical and HRCT features, not when classical and HRCT features are there, in which case no biopsy is not indicated. So, a multidisciplinary dynamic approach with the input of clinicians, radiologists and pathologists have been shown to improve diagnostic accuracy and is strongly recommended. In other words, histology is no longer a preeminent thing. They cannot be said as the final diagnosis. Clearly, training in applying guideline recommendations in the diagnosis of ILD/IPF should be directed not only to radiologists but also to pathologists and clinicians. Inter-observer variation is a significant problem. Multidisciplinary diagnosis in this disease group is relatively a recent phenomenon, and hence there is a need for clinician training in integrating and reconciling data to distill a final, more accurate clinical, radiological and histologic diagnosis. So, what are the HRCT criteria of IPF as of now? 1. We have done away with the major and minor criteria. The reason being, some of the minor criteria like a history of 3 to 6 months etc. are not relevant. Some patients may present acutely with an exacerbation. So, this is the currently accepted HRCT criteria. 1. Reticular abnormality and or traction bronchiectasis with basal and peripheral predominance. Second, honeycombing with basal and peripheral predominance. Third, atypical features should be absent if you want to make the diagnosis without biopsy. That means micronodules should not be there, peribronchiovascular nodules have no place, no consolidations, no ground glass attenuation. If at all they are present, they are much less extensive and predominant than the reticular opacity. Mediastinal adenopathy should not be there. Again, if it is present, it should not be as extensive to be visible on chest X-ray. In short, definite IPF means all the above three conditions are met, if met. Probable IPF means if 1 and 3 are met, that is the hallmark honeycombing is not there, but if 1 and 3 are there, it is probable IPF. Comparing this with this thing, again these details have been pictured here, how you look at the sure definite case and probable case and which are the inconsistent features. It is a classical case of idiopathic pulmonary fibrosis. Both axial and coronal images have been provided to show the temporal heterogeneity as well as the basal and peripheral predominance of reticular markings. This is a microscopic specimen. You can see even in this specimen that a lot of honeycombing lesions are seen in the lower lobes, but relatively normal lung is seen interposed especially in the upper lobes. Incidentally, has IPS been a disease of celebrities? Somebody has looked at that point and has found that quite a large number of actors, musicians and artists, not only in the West, even in India, or as we know at least in Kerala, have been known to have diagnosed with idiopathic pulmonary fibrosis. In my little state of India, Kerala, at least one of our great scholars and poets and at least two of our artists were known to have this disease. I have permission of my classmate friend to keep this picture in my teaching presentation. He was a psychiatrist, he was my medical school classmate. I visited him at work few years ago. He was in idiopathic pulmonary fibrosis being followed up. As happens to most of the patients, at during one episode, he had accelerated IPF, to which finally he succumbed. And it is at the same time newer things came, like the trial reports of the drug called pyrifenidone, etc. came, but actually pyrifenidone is been accepted for treatment primarily in Europe, and the clinicians are of different opinion regarding the use of it as a definitive drug. And how will you then treat recommendations? How will you then treat idiopathic pulmonary fibrosis? As discussed, no single pharmacological agent was recommended for use in the treatment of in patients with IPF. Currently, the approved option in Europe is pyrifenidone. Physicians hence must discuss the available options with individual patients and then make a treatment decision with the patient based on their specific values and preferences. As we always know and we accept, fully informed patients are best placed to make decisions that are consistent with the best available evidences. More data has now become available regarding the efficacy and safety of pyrifenidone, and also in terms of safety of immunosuppression based triple therapy. But excellence is actually doing ordinary things extraordinary well. And what will you do about unclassifiable diseases? This is why I brought in the simile of elephant in the room, that is patients who do not fit into a classification, and they are a quite big group really. In 2011, the great pulmonary radiologist Fleischner has remarked that at least half of the idiopathic cases do not fit the current classification, and Kevin Brown has opined that in his place Denver, at least 30% cases could not be classified. So what do we mean by unclassifiable disease? Which means tentative first choice diagnosis but no convincing differential diagnosis, and also overlapping features and no plausible first choice diagnosis. All these three will come under unclassifiable diagnosis. But these cases account for at least 25% of all interstitial lung disease cases, and that is why it causes the confusion. To what extent does evidence based treatment meet their needs? Regarding managing unclassifiable disease, the problem is evidence based management can be applied to overlapping disorders, but by definition no evidence base exists for completely unclassifiable disease. Therefore, an alternative classification approach is required. More nuanced terminology is not the answer. For example, look at all these terminologies: constrictive bronchiolitis, follicular bronchiolitis, proliferative bronchiolitis, obliterative bronchiolitis, bronchiolitis obliterans organizing pneumonia, so on and so forth. These do not benefit the patient at all. Therefore, we need a different question which will need to different answer. Historically, the primary question which all of us used to ask were, what is the diagnosis? Pragmatically, the primary question is, what are you going to do about it? There are about over 1000 interstitial lung diseases, but only few management and monitoring strategies. We therefore need a pragmatic classification of ILD using simple terminology. So we are coming to the last part of it. So the pragmatic classification has got specific diagnosis, it should have a cause, predominant morphologic abnormality, look at it, look at the severity, and look at the longitudinal behavior. And this is what we are going to do finally. There is a group called reversible and self-limited. Typical example is RBILD, the smoker's lung disease, in which case just remove the possible cause, short term observation, is only indicated to confirm that the disease is regressing. Second group is reversible disease with risk of progression. Example, some cases of NSIP, DIP and cryptogenic organizing dysphonia. Get an initial response and then rationalize longer term therapy. Again, short term observation to confirm treatment response, long term observation to ensure the gains are preserved. Third group is stable with residual disease. Example, some NSIP. Maintain the status. Just have a long term observation to assess disease course. Fourth is progressive irreversible disease with potential for stabilization. Example, some fibrotic NSIP. Here our goal should be to prevent progression and long term observation to assess the disease course. Finally, we have a severe group which is progressive irreversible disease despite therapy. Example, idiopathic pulmonary fibrosis and some cases of fibrotic NSIP. Here you should only aim at slowing the progression of the disease, that is long term observation to assess disease course, to assess the need for lung transplant or effective palliation. In summary, now the diagnosis and classification of idiopathic interstitial pneumonias are driven more and more by the multidisciplinary process. Idiopathic NSIP and idiopathic pulmonary fibrosis are clearer entities now. Lipoid interstitial pneumonia has been demoted to a rare category along with the new entity of idiopathic pleuroparenchymal fibroelastosis. And the last point which I was trying to highlight is there has been a birth of a disease behavior classification which is the need of the hour. Thank you.